So I would like to introduce Dr. Madhur Unyal, who is at AIIMS Rishikesh. I'm happy to welcome him for the first time in Jaipur Surgical Tutorial, and actually his name has been recommended by Dr. Puneet Dhar. I had earlier requested Puneet, but he was gracious enough to suggest that Madhur could cover this topic. Welcome Madhur to Jaipur Surgical Tutorial, and we hope to see you in more and more of our sessions in future also. So Madhur is going to talk to us about the principles of management of pancreas.
Thank you, sir. So good evening all. I'm Dr. Madhur, like sir said, and I'll be talking about pancreatic trauma management principles. So I have nothing to disclose. So I want to begin by saying that the signs and symptoms of pancreatic trauma are always, they depend upon associated injuries, which are quite very much. So 19% of them have associated liver injuries, 16% of them have stomach injuries, 11% splenic injuries, 8% colonic injuries, 8% duodenal injuries, and other injuries as well. So basically, they will all the effect of all these injuries will overlap. So describing signs and symptoms and presentation will be a part of primary and secondary assessment of these patients. So whenever we talk about primary assessment, the ATLS way, the first thing that comes into our mind is MIST, which is the pre-injury information format. It stands for mechanism, injuries, signs and symptoms, and treatment. So what mechanism do these injuries usually have? So you can see the clothesline injury when somebody is driving a motorcycle and there's a clothesline which he fails to see. It hits him in the upper part of the chest. Probably the bumper of a car hits a person in the upper part of his abdomen. Somebody strikes the patient, or seatbelt injury like Dr. Shastri told. So all these injuries, they involve a linear force in the upper part of the abdomen. The literature says that blunt injuries are much more commonly associated with pancreatic injuries than penetrating injuries. And 80% of these blunt injuries, road traffic injuries, are the culprit. What usually happens is there is a strong linear force in the upper part of the chest. It crushes the pancreas against the spinal cord. And then there is compression against the spine, and usually there is contusion or laceration of the pancreas, and this usually occurs at the neck or proximal body region. This patient, of course, we have to follow the ATLS protocol when they reach our ED. So first what we do is we look at the airway, we see whether the airway is patent or not. If the GCS of the patient is not that low, not less than 8, so that his tongue might fall back. If there is no regurgitation, no foreign body in the mouth, no saliva, we clear the airway and stabilize the cervical spine. Then we look at the breathing and ventilation part of the patient, whether the chest is rising equally on both the sides, whether there is less air entry, showing there might be a pneumothorax or a hemothorax, whether there are chest compression tests, which is the allotment of one hemithorax followed by the other to look for any bony crepitus or surgical emphysema. And of course, the saturation, which we see on pulse oximeter. Then the circulation part comes in the part of the management where we put 2 IV bore cannulas, draw samples for blood cross and cross matching, look at the patient's heart rate, whether it is indicative of any tachycardia, blood pressure and all, whether they're indicative of any hemodynamic instability, and pelvic compression test, whether it is associated or not, and FAST examination. FAST is focused assessment by sonography for trauma, which has come up, which has become now a stethoscope in the primary and secondary survey, and which looks for fluid in the peritoneal cavity and tells us whether the patient might be bleeding because of trauma. All these things, if there are any problems, they manage simultaneously and do not follow in the scope of this presentation. We look for the disability where we see GCS, where we appreciate whether there is an anisocoria or not, or whether lateralizing sign, whether the patient is able to move one half of the body more than the other because of some central nervous system injuries. And then of course, we examine the patient from head to toe and prevent the hypothermia. The main cause, the main purpose of primary survey is to save life or limb. So if we manage all these things in this manner, we might be able to save the patient. But you must realize, or you must have appreciated, but in all these times, pancreatic injury diagnosis has not come into picture, neither the suspicion of it. Because pancreatic trauma, they seldom lead to immediate loss of life. So when do they come into picture? The secondary survey. Secondary survey is head-to-toe examination of the patient, and everything else we do after primary survey to help that patient. So secondary survey in head-to-toe examination of the patient might reveal an injury, a bruise, or a contusion in the zone 1 of the hemithorax, which houses pancreas, duodenum, and the large vessels. This is a patient who shows a typical, bruise in the upper part of the abdomen in the zone 1. This might, after doing the primary and secondary survey, this gives us a hint of what diagnostic modality we should go for. And of course, also, it might raise a suspicion of pancreatic injury and aortic injury or large vessel injuries in these regions. So what radiology might be helpful in trauma emergency department? Ultrasound. Well, we all know that ultrasounds are usually, they fail to appreciate a retroperitoneal organ like pancreas, and most of the times bowel gas is one of the reasons. CECT, contrast enhanced computed tomography. It is fast. It can assess the patient in a fraction of a second. It is very good tool to even assess other injuries in the body, be it soft tissue, solid organ, or bony injuries. And it can be easily done in an ED patient. So, though the pancreatic duct injury, which we have based our talk, that it is one of the primary indications for intervention, it might not be picked very well by CCT, but it picks everything along with a high index of suspicion for pancreatic trauma. MRCP, like the discussion with that, if there's a high index of suspicion, then MRCP is a choice. ERCP is also a choice. It is very accurate. The specificity is the highest of everything and else, but it's an invasive procedure, only to be done in times of when the patient is absolutely stable. There are no other associated injuries. Sometimes in grade 3 pancreatic injuries with one wall intact, ERCP can also be therapeutic. So this is a typical radiological plate of a CT patient with pancreatic trauma. This is the almost the location where it usually occurs, at the junction of the neck and the body. And there is a hypoechoic shadow, which is the break in the continuity of the parenchyma of the pancreas. And how do we know that it's a CT scan, ductal injury? How do we know? So it is taken that if more than 50% of thickness of pancreas is crossed by this hypoechoic line, then we consider that the MPD violation has been done. Of course, there are other signs as well, like peripancreatic collection, fat stranding, swelling, and all those things. But this is the primary thing which we look for while examining a CT of the patient. CT of the patient, unfortunately, is also not very sensitive in first 12 hours. So small injuries can be missed in first 12 hours. And these injuries might later on present while evaluation of the trauma of the patient as increasing abdominal pain, which you cannot account for. It can also present by increasing abdominal tenderness, persistent vomiting, or inability to tolerate oral light. Everything is fine. Patient is tachycardic, tachypneic, is vomiting frequently, not able to tolerate oral diet, unexplained hypotension, leukocytosis, and increasing might look for. Explained just before. So I will just try to use it for the management plans. So these American Association of Society for Trauma guidelines are radiological guidelines. They are not intraoperative guidelines. They are radiological guidelines. So I'll just go through brief. The first is just a hematoma. Second is injury, which is there in the pancreas. One which I want to.
Madhur, we seem to be losing your
mesenteric vessels. And fifth is shattered head of the pancreas with associated duodenal injuries or complex injuries. So with this thing, I want to say that the operative indication starts from 3, or any intervention starts from 3. So violation of the...
But in the meantime, Kishore, the other classifications, is there some evidence to support or to say that they may be more practical and more useful than the AAST?
Sir, is my slide visible, sir?
Yes, now we can see. Yes, please. Right. We'll take that question later. Please go ahead.
So basically, 3 where the intervention starts, and 4 and 5 definitely we have to do something about it. So I'm very sorry, sir. My presentation has flunked. I think my PowerPoint is also not visible, but I'll talk about it. So what do we do when we have the decision for intervention is there? If there are no associated injuries, then the patient can be taken to, if a wall is intact, then ERCP can be a good modality where, so now what do we do when there is what type of incision? If the patient has to be operated, there's surgery, then what incision do we get? It is of a great help here. So what do we do then? Then so by holding the gastrocolic ligament, we hold the colon in our right hand, we pick it up, the gastrocolic ligament is there. So what happens is, sir, the patient is taken to your, a large vertical midline incision is given. A Thompson retractor is of a great help. The colon is lifted, the transverse colon, and the gastrocolic ligament is there in front of the surgeon. Protecting the both the epiploics, it can be opened by a cautery or by energy source, and then there is an entry to the lesser sac. Here I must say that there is a sign which has been described in literature, Mishra's sign, which has been given by my faculty in AIIMS Delhi only. Mishra's sign say that if there is a hematoma or a laceration in the lesser sac, there's likely to be a pancreatic injury. So it is a highly sensitive sign. So whenever, before even opening up the lesser sac, we have to inspect the lesser curvature of the stomach and the lesser sac there. If there is a hematoma or if there's a laceration, it is an indicative of a pancreatic trauma inside. So after opening up the gastrocolic ligament, usually we see signs of saponification or we see some collection of a pancreatic fluid. So following that, we easily reach the surface of the pancreas. We create a space there, and then we usually see a hematoma there, and on debridement of that hematoma, we reach surface of the pancreas. Of course, we have to open up the entire capsule to appreciate the anterior surface of the pancreas. If it is grade 3, which is distal to the superior mesenteric vessels, which is in most of the cases, the condition is there, then a distal pancreatectomy would suffice. Gently lifting up the pancreas of the splenic artery and splenic vein and proceeding distally, we are able to do distal pancreatectomy. And if you are able to save the vein and the artery, then most of the times we are able to preserve the spleen. The usual trick of the trade is either if you don't have an energy source like LigaSure or Harmonic, we can use 100 clips. There are multiple caterpillar vessels which feed the pancreas from the artery and the vein, and we can ligate them very well by an endoclip or a 100 clip. Or if we have an energy source, nowadays the LigaSure is very user-friendly. It has also come articulating, and it is very helpful in dissecting the pancreas of the pancreatic bed. The proximal stump then has to be taken a great look at. It can be cauterized. Cauterizing it sometimes cicatrize the pancreatic duct, which in most of the cases is very difficult to appreciate while operating a pancreatic trauma. So after doing that, the fold of omentum is taken and it is kept over the pancreatic stump, and later on with the hope that it will seal off the pancreatic injury and there is no pancreatic fistula which develops later on. So this is the basic step which is there. Of course, it is proximal. What to do then if it is proximal to superior mesenteric vessels? Initially, the literature said that almost around 80% of the pancreas can be sacrificed without any signs of pancreatic insufficiency. And now the newer studies have revealed that even 90% can be safely excised. Only 10% of remaining pancreas are sufficient enough to not cause pancreatic insufficiency. So even in grade 4 injuries, which are just near the superior mesenteric vessels on the right side, on the proximal side, and if you think that 10% of pancreas is remaining and it can be saved, so it should be done, because the other option requires many anastomosis, and of most of the times these patients are on inotropes, which are a major cause of failure for any difficult anastomosis. The grade 5 is usually ends up into traumatic Whipple's, which we call. There's pancreadodenectomy with the gastrojejunostomy, and sometimes dunking is done. So pancreaticojejunostomy is an option here. So what post-op things after operating, after dissecting the pancreas out, and in most of the cases when it is the distal pancreatectomy which we do, we place usually 3 drains. we place 2 drains at the bed and 1 drain in pelvis. These 2 drains can be used to irrigate also later on, because of course some leaking is there after the pancreas, which is mostly appreciated by patients developing tachycardia more than baseline. And so the wash can be given, and it usually solves the problem. And a drain is kept. Like Professor Shastri initially said, the importance of amylase and lipase, it is very important in the post-operative period, especially when we have to make a decision to remove the drain. We check the serum amylase and lipase, and if they are 1/3 of the baseline, we think that it is the time to remove the drain. So what post-operative complications, what other complications can occur which are associated with the pancreatic trauma? The other complications associated with pancreatic trauma is a pancreatic fistula, which is the most dreaded complication. Here, I just want to add that pancreatic fistula, somatostatin inhibitors, they don't cause any health. They just manage the fistula. But if you see the evidence, there is no evidence that suggests that they have any action on healing of the fistula. Pancreatic pseudocyst in around 20% of the cases is there. And sometimes in unoperated patients for a long time, it can be seen. And cystogastroscopy is one of the options nowadays, done very well by endoscopic methods. And laparoscopic too. So these are the basic things. One thing we have to look after the surgery for pancreatic trauma is feeding. Enteral feeding, unlike the large NPO status in the earlier days, has come into vogue. It has to be started early. Post-pyloric feeding is preferred. So at the time of surgery, it is usually it helps a lot to negotiate the Ryle's tube distal to the pylorus, or otherwise a feeding jejunostomy is also an option. Spine has to be inspected very well whenever you are expecting a pancreatic trauma. We have always to look twice at the spine, that because more than 18% of pancreatic trauma have spinal injuries associated with them. So these patients usually require a very good care in post-operative care in ICU, where they have to be looked for all the things, especially the chest has to be, they have high tendency of developing pleural effusions. They have and pancreatic fistula and all those things. So they have to be meticulously seen in the post-operative care in ICU. And if surgery is done well, and if they are done in earlier they have been done, the better the outcomes are. And but nowadays, if there's a grade 3 injuries and surgical expertise is there, even post-operative day 10 are being operated with a good outcome. So thank you, and I'll be open for any questions. I'll be happy to address them.
Mathur, yeah, Dr. Shastri, please.
Yeah, thank you, Mathur. Yeah, the principles of management of pancreatic injury you have clearly shown. But then my question is, if you see the recent literature, like all solid visceral injuries, conservatism is recommended in majority of pancreatic injury cases also. So we have, later probably I can show our own publication of say 84 cases or 92 cases of pancreatic injury, and 34 of them grade 3 and grade 4, and only 8 were operated early. And rest of them, some of them were operated late, and we did not find any difference in the complications or the morbidity or mortality. Even patients who had developed pancreatic fistula with a pancreatic ductal rupture did not do that badly, in the sense that we did not lose them. Yes, morbidity did increase with a pancreatic fistula, but that could be managed. Or a post-trauma pseudocyst or any of these could be managed later once the acute phase is crossed over. This seems to be the trend. What is your opinion on that?
Sir.
Conservatism in grade 3 and grade 4 injuries.
So conservatism is increasing all the solid organs, and that is more because of the emergence of intervention radiology. So most of the spleens which we used to take out earlier can be managed very well by angioembolizations, and so is it for liver, which is much more common than spleen, which we realized later on after the coming of CT that liver is much more forgiving and it was being managed. Unfortunately, intervention radiology has not much role, but endoscopy sure has a good role in ductal injuries. So in isolated ductal injuries or isolated pancreatic injuries, if the patient does not have comorbidities and one side of the wall is intact, and if there's a good endoscopist, it is possible to do interpapillary stenting and go for a thing. I'm very happy to hear about your experience, sir, but still, the protocol and still the evidence which we have studied and which I've studied a few days ago and from AIIMS Delhi also was pointing out towards operative management of grade 3. So I'm really intrigued by a study. I would like to definitely go for it, read about it, but it should be seen, sir, definitely with increasing options. The only thing it is there, sir, that if operated in time, they have wonderful outcomes. But if we do delays, thinking about managing them conservatively, then later on, sometimes even the operations are very difficult to, it becomes very difficult to perform surgeries on delayed pancreatic traumas.
So at surgery, is it possible, is it an option that if suppose the pancreas is divided into two pieces and you don't want to sacrifice a major part of the distal pancreas, but is it an option that you place a stent across operatively, one limb into the proximal, one into the distal, and provide good drainage? Yes, there will be pancreatic fistula, but as Dr. Shastri said, then it becomes a controlled external pancreatic fistula, which you can handle later by whatever methods you want. So is that an option?
Sir, theoretically, it sounds like an option, but since the alternative is so simple that you do a distal spleen preserving distal pancreatectomy and you close the proximal stump, that would be a risk which we would be taking. The alternative is very simple, and usually the outcomes are very good.
Yeah, but I'm not convinced by the evidence. I will have to go into it in detail because see, when we do pancreatoduodenectomy, we are removing only about 40 to 50 or maybe maximum 60%, and still there is a significant long-term risk of exocrine and endocrine insufficiency. So why is it that in trauma, you said that just 10% is good enough?
Sir, so this is not my saying. This is an evidence which has been generating. And if you talk about our experience, so last month we operated about 5 of them, and 2 distal pancreatectomies were proximal. So we had a very good outcome with them. But of course, on the evidence pyramid, it's not even 6. But the literature points out that about 90% of the pancreas can be removed. The current literature says that it can be removed without any thing for insufficiency.
And
so
these studies have long-term follow-up, 2 years, 5 years, 10 years.
The evidence for 80% has been since long time, sir. The 90% we'll have to look at it. That how much long follow-up is there.
One more thing we have to look into here is we are talking of a normal pancreas, not a diseased pancreas.
True.
It's I think it's criminal to sacrifice 90% of pancreas, hoping that nothing would happen. It is not fair. As Dr. Vinay was suggesting, we also did. In fact, my own resident, who is a professor now, he has a series of 8 continuous cases of grade 3 and 4 injuries where ductal disruption was there. I think 4 or 5 of them were clean cut, but 3 of them had contusion in addition, where he debrided, brought the 2 stumps together, and with a nasal feeding tube or a celastic tube which the neurosurgeons use for their shunts, stented it across, and in fact did a ductal anastomosis. And he has a 4 or 5 year post repair follow-up showing very good pancreatic duct and the preservation of pancreatic parenchyma. So what I want to emphasize is a conservatism in terms of not only the surgery, but conserve the pancreatic parenchyma too. And it is well evidence that even when you resect, what we do is if we resect also, if it is a proximal resection, we don't do the definitive anastomosis at that stage. We do a stage procedure. We must remember that these patients have a lot of associated injuries, and they are physiologically disturbed, and doing a full-fledged Whipple's is problematic, and they just fraught with a lot of complications. It is not only that, the diagnosing the pancreatic injury on table is not that as simple as we've been saying. Like say, ductal disruption is so very well seen, obvious, and then you take a call on whether to do a proximal or distal pancreatectomy. It is not that simple. Things are confused, partly necros. See, it is not as though we operate immediately. There are hematomas there. It is sometimes very difficult to even diagnose a ductal disruption without, doing too much of a debridement there. And it is also important to emphasize here the complicated dissections in a traumatized retroperitoneum around the pancreas. We can do a lot of collateral injury. I think that needs to be avoided. But I think it's an important lesson we must give to the junior colleagues who are too aggressive about pancreatic injury management. I think it is something which we have learned over these 30 years. And we operate when there is a hemodynamic instability. When you have a definite ductal rupture signs, we definitely first try a ARCP and ductal stenting. And if it is not possible, yes, we do operate. But again, a conservative surgery in terms of simple drainage, simple ductal drainage, or resectional drainage, depending on the situation which you are seeing there, but not do complicated repair procedures there. This is one thing which I thought I wanted to emphasize, and we have evidence now. All the recent grade 4, grade 5 injuries that are reported in the literature, there is the incidence of conservatism is much more evident than immediate surgery, unless there is a contusion of the pancreas, there is ductal rupture, and hemodynamic instability. These are the three things which we always look into before you decide.
Madhur, in a grade 5 injury, if we have to do a resection, as you said, then is exteriorization an option? And if exteriorization, obviously the pancreatic duct, what about the biliary and the gastric or duodenal?
So in which cases? I beg your pardon?
Grade 5 injury, we have to do resection, pancreatic or duodenectomy. So instead of doing the anastomosis in a polytraumatized, hemodynamically unstable patient, is exteriorization at that stage and reconstruction later?
So, well, that is the primary principle of damage control surgery in a traumatic patients. So if the patient is on ionotropes, is acidotic, any of the radical procedures are deferred. So exteriorization is definitely an option. But there has been an option also that while operating these patients, so if the patient is stable and we have to do an anastomosis, for example, a hepaticojejunostomy is required. Now cystojejunostomy is usually an option as well. So it is coming up in literature recently that because usually hepaticojejunostomy we do for common bile duct injuries in other cases. But in trauma and in common bile duct injuries, usually the bladder is gone already, gallbladder is not there. But in these cases, even cystojejunostomy is an option which is much more easier for younger people, people with less experience to do. But to answer your question, definitely exteriorization should be considered if the patient is unstable due to one reason or the other.
Yeah, so just to clarify, when Dr. Madhur says cystojejunostomy, he means a cholecystojejunostomy.
Cholecystojejunostomy.